Welcome back to the deep dive. We are doing something a little different today. Usually we take a wide-angle lens to a topic, but today we are zooming in, I mean microscopically in.
Yeah, we are getting incredibly specific today.
We really are. And please start by sharing the source of this video. We are looking at a single medical training video today. It's titled HCC 1475-16B Hot Biopsy Forceps, and it comes directly from the archives of Dr. Gautamukala S. Raju.
Right. It's a very technical piece of source material, basically an absolute masterclass on how to use, and just as importantly, how not to use one highly specific tool in endoscopy.
Yeah.
But what I really love about this deep dive is that it's not just some dry instruction manual. It's a lesson in physics and anatomy, and honestly, it's about clinical judgment.
It really is. And the tool in question here is the hot biopsy forceps. Right off the bat, I mean, the name itself implies this duality. You have the forceps part, which is just a mechanical grabber, and then hot, which obviously implies heat or, well, electricity. It's a hybrid.
Exactly. It bridges this gap between mechanical surgery and electrosurgery. And as we'll see, that bridge is exactly where all the danger lies for the patient.
So let's just visualize this thing for you listening at home since you haven't seen the video. If I'm a doctor holding this device, what am I actually looking at?
So you're holding a long, very flexible wire, and it's encased in a plastic sheath. At your end, the handle part, you have what's called a thumb ring.
Okay.
It looks a lot like a standard pair of scissors or maybe the grip of a syringe. And then at the very other end, the tip that actually goes inside the patient, you have two small metal cups, jaws, basically.
Like a tiny Pac-Man.
Sure, yeah, tiny metal Pac-Man. Mechanically, it is super simple. You push the thumb ring in, the jaws open. You pull the thumb ring back, the jaws close.
Right.
If that's literally all it did, it would just be a standard cold biopsy forcep.
But Dr. Raju points out a specific modification immediately in the video. The active cord.
Right. So there is a connection port right there on the handle. You plug a cord into the forceps, and the other end goes into an electrosurgical unit.
Which is essentially a generator, right?
Exactly, it's a generator. And this turns the entire metal core of the wire all the way down the tube to those little metal jaws into an electrode. It conducts electricity.
Which changes the stakes completely. You aren't just grabbing tissue anymore. You are completing an electrical circuit.
And that is the first big concept the source tackles, the circuit itself. Because you can't just plug the forceps in and start, zapping things.
Right. Electricity needs a path to flow.
It needs to enter the patient, do its work at the surgical site, and then it has to leave the patient safely.
The video actually mentions a grounding plate. I think most people have probably seen this in movies or TV shows, the sticky pad they put on a patient's thigh during surgery. But I don't think most people understand why it's actually there. Like, why doesn't the pad burn the patient if the forceps do?
That is the crucial question, and it all comes down to current density. Think about it like water flowing through a funnel.
Okay.
At the tip of the forceps, the surface area is tiny. We're talking just a few millimeters. So all that electrical energy from the generator is squeezed into a very, very small point.
Right.
That high density creates intense heat, and that's what allows us to burn or cut the tissue.
Okay, so high density equals high heat.
Exactly. But the electricity has to leave the body to return to the generator to complete the circuit. If it left through another tiny point, say, if the patient's bare arm was touching a metal table rail, it would burn them right there too.
Which would be an absolute disaster.
You're right. Severe unintended burns. So we use the grounding plate. It has this huge surface area relative to the tiny forceps.
Oh, I see.
When the current reaches the plate on the thigh, it spreads out. The density drops effectively to zero. Low density means no heat. So the current exits the body safely without causing a burn.
That makes perfect sense. So the patient is literally just the resistor in the middle of this circuit.
They are part of the wire. And the switch for this circuit, interestingly, isn't on your hand. You're holding the forceps, you're maneuvering the scope, looking at a video monitor, but your foot is doing the firing.
The pedals on the floor.
The foot pedals. It is a serious coordination test for the doctor.
So, okay, we have the machine set up. We understand the circuit. Now, Dr. Raju outlines two very specific physiological goals for this tool. Basically, two reasons you'd actually want to electrify a pair of forceps in the first place.
The first is hemostasis.
Stopping bleeding.
Yes. And the second is tissue acquisition. That's actually removing a polyp or grabbing a sample for the pathology lab.
And reading through the source material, it really feels like these two goals are treated with very different levels of enthusiasm by the doctor.
That is putting it mildly, yeah. The video is essentially a comprehensive guide on how to use the tool perfectly for hemostasis, and then it serves as a massive warning label on why you probably shouldn't use it for tissue acquisition.
Let's start with the good use case then.
Yeah.
Hemostasis. Set the scene for us.
Okay, so you're performing a colonoscopy. Maybe you've just removed a polyp with a different tool, or maybe you just accidentally nicked mucosa, but you have a bleeding vessel. It's not a massive gusher, but it is oozing blood. You need to seal it.
You essentially need to weld it shut.
Exactly, weld it. So you bring in the hot biopsy forceps. Now, Dr. Raju is very specific about the settings on the generator here. He calls for something called soft coagulation. He specifically mentions setting it to effect 480 watts.
What does soft coagulation actually mean in terms of the electricity? Is it just turning it to low power?
It's not just the wattage, it's actually the waveform. Standard coagulation current tends to have these high voltage spikes, and those spikes cause sparking.
Yeah.
Sparking leads to carbonization, charring. Soft coag keeps the voltage below the threshold for sparking. It cooks the tissue slowly and deeply without turning it into charcoal. It allows the proteins to denature and just stick together.
Like cooking an egg white slowly until it goes solid rather than just blasting it with a blowtorch.
That is a perfect analogy. You want a clean seal, not a burnt crater.
Okay, so the settings are dialed in. You pass the forceps down the scope channel. You see the bleeder. Now comes the single most emphasized technique in the entire video. The tent maneuver, yes. If you take nothing else away from this deep dive, you have to remember this visual.
Describe it. What is the doctor physically doing with their hands?
So the instinct, and this is a very dangerous instinct, is to see the bleeding spot, press the hot metal forceps down against it, and just step on the pedal. Just mash and burn.
Like you're branding cattle.
Exactly. And if you do that in the colon, you are quite literally playing with fire. The colon wall is very thin. If you press down and fire the energy, the heat travels down. It goes past the inner lining into the muscle and potentially right through the organ.
A perforation.
Yes. You've just poked a hole in the intestine. That is a major surgical emergency.
So the tent is the safety mechanism to prevent that. Yes. Instead of pushing down, you gently grasp the bleeding vessel with the jaws of the forceps. And then, this is the key, before you even touch the foot pedal, you pull the forceps back into the empty space of the colon. You lift the tissue up.
You're tenting the lining away from the muscle wall.
You are creating a physical air gap. You totally isolate the vessel. Now, when you step on the pedal, the current flows through the forceps, cooks that little piece of tissue you're holding, but the heat cannot travel down to the muscle because you've pulled it away.
That is such a fascinating interplay of mechanics and electronics. You have to physically move the target to make it safe to shoot.
It's critical. Dr. Raju says you hold the pedal until you see a white coagulum form.
That egg white seal we just talked about.
Right. Once you see white, you let go of the pedal, the vessel is sealed, the muscle wall underneath is completely untouched. That is the textbook safe use of the hot biopsy forceps.
Okay, so that's the success story. That's the green light. Now we have to move to the red light, the big controversy. The second use case, which is polypectomy.
This is where the medical history really matters. The source notes that in the past, training videos and older doctors often encourage using hot biopsy forceps to remove small polyps. The whole idea was efficiency.
Grab the polyp, turn on the juice, and just burn it off.
Yeah, simultaneous coagulation and cutting. You burn through the base of the polyp while pulling it, the polyp comes off, and because you burned it on the way out, there's no bleeding. It sounds great on paper.
But Dr. Raju is waving a massive red flag here, and he points specifically to the anatomy to explain why. He mentions the right colon, or the cecum.
The cecum is the very start of the large intestine, and the defining characteristic of the cecum is that the wall is incredibly thin. We are talking paper thin.
So your margin for error there is basically non-existent.
It effectively is. If you grab a polyp in the cecum and apply that coagulation current, even if you think you're being careful and tenting, that heat spreads. It radiates outward. And because the wall is so ridiculously thin, it can cook the full thickness of the organ very, very quickly.
And the source mentions a specific type of complication here called delayed bleeding.
This is the silent killer aspect of thermal injury.
How does that actually work? Why is it delayed?
Well, if you accidentally cut a hole with a mechanical knife, you see it immediately on the camera. But a thermal injury is completely different. You might burn the tissue deep down, but the wall itself is still structurally intact for now.
Right, it looks fine on the screen.
Exactly. The patient wakes up, they go home, they feel completely fine. But that burned tissue is actually dead. It's necrotic. And over the next few days, it starts to naturally slough off.
And when it finally falls off.
The wall just gives way. 3, maybe 4 days later, the patient suddenly has a perforation or a massive internal bleed at home.
That is terrifying. So the supposed efficiency of burning the polyp creates this ticking time bomb.
Exactly. But there's actually another reason to hate this hot technique. Even if you miraculously don't hurt the patient, it totally ruins the science.
We're talking about the pathology report now.
Right. The whole reason we remove polyps in the first place is to test them. We need to know, is it cancer? Is it benign? The pathologist needs to look at those specific cells under a microscope.
But if you've used a hot forceps,
You've cooked the sample. The source mentions specifically that coagulation current causes charring and artifacts. The edges of the polyp, the margins, which, by the way, are the most important part to check for cancer, are turned into burnt toast.
so the pathologist looks at the slide and literally just sees carbon.
And they can't give you a clear diagnosis. So think about the trade-off here. You took a huge unnecessary safety risk by using heat in a paper-thin organ, and you simultaneously destroyed the diagnostic value of the tissue you just removed. It's a total lose-lose situation.
So what is the alternative then? If I'm a doctor in the right colon and I see a small polyp, let's say under 5 millimeters, and I have these hot forceps right there in my hand, what does Dr. Raju actually want me to do?
He wants you to ignore the core, pretend it's not even plugged into the wall.
He calls for cold biopsy.
Cold biopsy. You use the exact same tool, but you do not touch that foot pedal. You just use the mechanical jaws to bite the polyp off.
Just a simple mechanical snap.
Yes. For small polyps, the bleeding from a cold bite is usually very minor, and it stops on its own. But the safety profile is perfect. No heat means no thermal injury. No thermal injury means zero risk of that delayed perforation.
And the sample itself.
Pristine. No char at all. The pathologist can see every single cell perfectly.
It's so interesting because cold biopsy sounds almost primitive compared to hot biopsy. But in this specific context, the primitive method is actually the highly sophisticated choice.
It's the data-driven choice. We used to think zapping everything was better just because it was high-tech. Now we know that for small lesions, the mechanical bite is safer for the patient and diagnostically superior for the lab.
However, and I really appreciate this nuance in the source video, Dr. Raju seems to know that some doctors are just stubborn. He knows there are experienced people watching who are thinking, you know, I hear you, but I hate any bleeding at all. I want to use heat.
He does. He offers a compromise, almost a loophole for the stubborn ones.
He talks about switching the pedals, the blue pedal versus the yellow pedal.
This is really important physics to understand if you're going to be operating these machines. The blue pedal is standard coagulation. That's what we used for the bleeding vessel earlier. It creates a waveform that pulses on and off. It heats things up very efficiently to make them stick together.
For clotting.
Clotting, yeah. But that slow, spreading heat is exactly what we do not want when we're removing a polyp.
So he says if you absolutely must burn it, use the yellow pedal. Cutting current.
Pure cutting current, yeah.
How is the electricity actually different when you get yellow?
Cutting current is continuous. It's a constant, high-frequency sine wave. It doesn't pulse at all. When this hits the tissue, it heats the water inside the cells instantly, so fast that the cells essentially explode into steam.
It vaporizes them.
It totally vaporizes the tissue right at the point of contact. It acts almost like a lightsaber. Because it cuts so incredibly fast, the heat simply doesn't have time to conduct outward into the surrounding tissue.
So, theoretically, you slice the polyp off cleanly without cooking the thin colon wall behind it.
That's the theory, yes. It's cleaner, less char for the pathologist to deal with, and less thermal spread for the patient's safety.
So is that the final recommendation then? Just switch to the yellow pedal?
No, not really. That's kind of the trap. He explains how to do it, use yellow, not blue, but he still firmly frames it as a backup plan. He basically says, if you insist on using heat, do it this way. But really, you should just be using cold biopsy.
Even the safer heat is still way riskier than just using no heat.
Precisely. Because even with cutting current, you are still introducing high energy into a paper-thin system. You still have to do the tent maneuver. You always have to tent. But why take the risk? If the polyp is small, cold biopsy removes the variable of heat entirely.
It seems like the entire video is really a masterclass in restraint. You have this incredibly powerful tool, but the real mark of an expert is knowing when to keep your foot completely off the gas.
Or off the pedal in this case. It's about matching the tool to the specific anatomy. In the thick-walled stomach, maybe you can afford to be a bit more aggressive. In the paper-thin cecum, you need to be incredibly conservative.
I want to go back to the tent maneuver one last time just because the source is so adamant about it. Is there ever a situation where a doctor would apply current without tenting?
According to the source, absolutely not. If you cannot tent the tissue, you cannot burn it.
What if the polyp is perfectly flat? Or the angle of the scope is weird and you literally just can't lift it up?
Then you have to find another way. Maybe you inject fluid under it to create an artificial cushion. Maybe you use a cold snare. But you never, ever press the forceps flat against the wall and fire. That is the cardinal sin of this procedure.
It's the tent or nothing rule.
Pretty much, yeah.
There's one other detail I wanted to catch from the video. Dr. Raju talks about the thumb ring and the mechanics of opening and closing the cups. It seems so basic, but he spends actual time on it. Why focus on that?
Because it's all about tactile feedback. When you're doing a biopsy through a scope, you can't physically feel the tissue with your own fingers. You're meters away from the actual site. The physical tension in that thumb ring is your only true connection to the texture of the tissue.
You have to feel the mechanical resistance all the way through the wire.
Right. And when you're tenting, that feeling is critical. You need to feel that you firmly grab the tissue, and you need to feel the resistance as you pull it away from the wall. If you pull way too hard, you might rip it mechanically. If you don't pull enough, you're still too close to the muscle. It is a very subtle art.
It's amazing how much feel is involved in a procedure that looks so digital and distant on a screen.
It's still surgery. It's still a very hands-on procedure, even if the hands are effectively remote controlled.
So let's bring this all together for everyone listening. We've done a really deep dive into Dr. Raju's training on the hot biopsy forceps. What are the big takeaways?
First, you have to truly understand your tools. Know that the hot biopsy forceps is a dual-purpose instrument. It's meant for hemostasis stopping bleeding and tissue acquisition.
But those two purposes have vastly different safety profiles.
Correct. For hemostasis, we use soft coagulation. We absolutely must use the tent maneuver to protect the wall, and we weld the vessel shut. It's the perfect tool for that specific job.
But for tissue acquisition, like removing small polyps, we have to be much, much more careful.
The modern consensus, and Dr. Raju's very strong suggestion, is to avoid heat entirely. Use cold biopsy. It prevents deep thermal injury, it completely prevents delayed bleeding, and it gives the pathologist a much better sample to test.
And if you are the type of doctor who just absolutely needs to use heat on a polyp,
Then switch to the yellow pedal. Use cutting current. It's safer than coagulation, but remember, it's still not as safe as cold biopsy. And never, ever forget to tent.
it's a fascinating look at how medical practice actually evolves over time. We so often assume that newer and more power automatically equals better.
Oh, absolutely. But in this case, the evolution was realizing that the simple, primitive, mechanical bite was actually the superior technology for patient safety.
Which brings us to a really interesting thought to end on. If you're listening to this, think about where else in life we might be over-applying technology. We have this bias that electricity, heat, software, whatever the high-tech solution is, must be the best approach. But in the delicate environment of the right colon, less is more, literally saves lives.
It makes you wonder how many other fields have a hot biopsy problem where we're using the complicated, dangerous tool just because it's plugged in.
Wisdom is knowing when to just unplug the machine.
I think that's a very fair summary.
Well, this has been a journey through the right colon that I didn't know I needed, but now I feel very informed about current density and white coagulum.
It's knowledge you hope you never have to use personally, but it's very good to know that your doctor knows it.
Absolutely. Thanks for unpacking this with us.
My pleasure.
And to everyone listening, thanks for diving deep with us. We'll see you on the next one.